Thank you for inviting me. A few days before leaving, my wife said, "Why are you going to Oslo? You've already been there. There's so many places in the world that we haven't been." And the answer was not difficult. I have been to Oslo before, and I have always felt a special kinship with this country. My father's family was entirely Norwegian. When I came here for the first time in mid-1970s, I made some friends that have been lasting throughout all of these years. And I've always felt like this is my second home. So I'm gratified that so many of you are here this morning. I hope today is going to be educational. What I'm going to be talking about is going to be very familiar to me, and I hope stimulating for you. Stimulating in the sense that it will raise questions, stimulating in the sense that you'll hear things that you want to know more about, stimulating in the sense, best of all, that you hear things you disagree with. Because while I can get bored with the material I'm going to present, I rarely get bored if somebody disagrees with me. And so I urge you to feel free and even welcomed if you want to interrupt at any time. There's a microphone right over there, which you should feel free to access, and it'll make for a much more lively day for everybody if you have a chance to say what's on your mind instead of hearing what's on mine. Okay? Thank you. This one right here? Okay. Borderline personality disorder is a major public health problem, representing in the United States about 15 to 20% of all psychiatric hospitalizations and outpatient clinic visits. About 6% of the visits which people in primary care have, primary care physicians, about 9% of emergency room visits, about 2% of the general population. It's burden on healthcare has rarely been taken seriously into consideration. So that despite the escalating costs of healthcare, which are always in the news, the care given to this group of patients is very unstandardized, inconsistent, and often can be harmful. That forms a backdrop for this talk and for this phase in my career, where what I'd like to see is a shift in a rise in public attention to this disorder and a shift within mental health training programs so that every clinician gets basic training in how to treat these patients. Despite the development of evidence-based treatments, there is a remarkable shortage of the needed mental health professionals who have been trained and know how to work with these people. And this is a statement that I earnestly believe that every borderline patient who is seen by a mental health professional has the right to expect that that mental health professional will have had basic training about this disorder and about its treatment. That's certainly not the case now, and we're far ways from it, as near as I can tell, every place else in the world. There are a lot of reasons for this. Some of them have to do with the myths within the mental health profession itself about these patients. One of them is that borderline patients resist treatment. Actually, borderline patients, many of them actively seek treatment. Some who identify themselves as having this disorder do not seek it because they fear the treatment they'll get, or they get treatments which they fear. Non-compliance is likely when the treatment is ineffective, and that should not be blamed on the patient. Between roughly 1974 and 1990, 54 books were written by psychoanalysts about treatment of borderline personality disorder. They documented all the problems that they encountered and called this treatment resistance or negative therapeutic reactions. The fact is that the conditions under which psychoanalytic therapies are given actually made patients worse. The neutrality encouraged the projections, which were then seen as part of the psychopathology. The interpretations of negative motivations just made patients feel more alienated and was experienced as blaming. And the passivity of the psychoanalytic stance encouraged fears of disinterest and neglect. The second myth is that borderline patients angrily attack their treaters. Well, borderline patients actually angrily attack a lot of people. It's just that if you're a professional, you may expect better treatment from your patients, and/or you're unaccustomed to seeing the anger of patients as a symptom of their problems, as opposed to taking it personally, that you're a good person doing your best. Why should you be treated this way? After all that money you spent to get all this training, it's an insult. It's your role to see this as a problem that the borderline patient has throughout their lives, maybe especially in relationship to caretakers, and to see it as a symptom rather than taking it personally. I'll return to this, but certainly even now, as recently as a month and a half ago, there was an article in the New York Times referring to some failed treatment trial, medication trial with borderline patients, which referred to the idea that in the absence of a medication, these patients were untreatable and intractable. And that remains a sort of prevailing myth. The recurrent risk of suicide will so seriously burden you all as potential treaters that who needs it, and when you can see patients who are not so difficult. It is true, I don't mean to minimize it, that many other types of patients are easier to treat. But if you have a serious feel that you're treating somebody who's at serious risk for suicide in an ongoing way, more often than not, that means that you have taken on too much responsibility for this patient's welfare and that the treatment needs to be restructured. Once again, it's not inherent in the patients, but oftentimes a failure to provide adequate supports for the patient. BPD borderline patients get better only if given extended and intensive treatment by experts. Again, this workshop today, I hope, will directly address that issue. You don't need to be an expert to be good enough for the vast majority of patients, and it does not need to be an extended treatment or an intensive treatment. The first wave of empirically based treatments dominated by dialectical behavior therapy, but followed soon after by mentalization-based treatment and transference-focused therapy, and to a lesser known extent, the cognitive analytic therapy, all measured themselves against treatment as usual. When it became clear that borderline patients could be treated with these empirically validated treatments, it became unethical then to have a comparison treatment which was treatment as usual, that is, no particular treatment. You had to, for ethical reasons, provide a treatment which could be less intensive and always was, but had some model that made sense, and by clinicians who were following a model that was likely to be not harmful to the patients. So all of in every instance, the second wave of treatment compared these pioneering evidence-based treatments against supportive treatments, usually once a week. And the remarkable thing was that when that was done, the differences between the pioneering evidence-based treatments, dialectical behavior therapy, cognitive behavioral, mentalization-based treatment, transference-focused therapy, and the cognitive analytic therapy, the differences between them and the comparative treatment became very modest. Well, what that means is that you don't need to have all that training, and borderline patients do not need such intensive programs for the majority of them to get well. Specifically relevant to me was this trial by Shirley McMahon and others in Canada, a large multi-site study, which compared what was then called general psychiatric management to dialectical behavior therapy. Up until that point, that was me sitting comfortably between my friends who were oftentimes antagonistic and competitive with each other about the value of Kernberg on the left, transference-focused psychotherapy, and Bateman on the right, mentalization-based treatment. And I was standing on the sideline sort of enjoying the differences, learning from them both, but I had no hat in the ring. Well, when this study was done, I'd consulted on it, and they used a book that Paul Links and I had written in 2008, I think it was, as sort of the basis for a manual for the comparison treatment, the general psychiatric management. When it turned out to be function as well as a DBT, I thought, oh my goodness, we have something that should be marketed. It deserves its own acronym, so hence GPM was born. The outcome in this study equaled DBT in most respects. There might have been some advantages to it, actually, but they're not significant. The remarkable thing about this was that Marcia was the one who let me know about the results. She sent me an email. She said, well, I always knew you did some, the model that you've written about, which I had not thought of as a model up until then, just good sense, was a diluted form of DBT. But she also said that the DBT given in this treatment trial was first rate. That's quite a concession, because almost always if you've got a favorite child in a race, if they don't come out first, it's because of unfair management. In this instance, she said that the DBT was actually first rate, and I've always been grateful to her for that. Structure of good psychiatry. You all following me so far? This is providing a rationale for why I went on this mission about maybe 4 years ago, something like that, where I'm doing this. I feel like there's a less intensive model that can be provided by people who don't specialize in borderline patients, who can serve the majority of borderline patients well, and that should be widely taught and widely used. It's a once-weekly treatment. As you'll hear, it's very psychoeducational. It starts out with the disclosure of the diagnosis and an open discussion about its course and its etiology. And that way it medicalizes the condition. It's focused on life outside of treatment as opposed to the interactions within the office, within the therapy. And it's both psychodynamic and behavioral, and it's very flexibly multimodal. I have to say that some of what made it distinctive now has been adopted by the other evidence-based treatments because it just makes sense, and because when the good psychiatric management got formulated and the handbook about its manual got written, we were integrating knowledge about the course and etiology of this disorder, which were not available when DBT and TFP and MBT were originally developed. So this treatment is not meant to displace or replace those very worthy forerunners. It's meant to be the treatment that every borderline patient should receive, and if they fail at this, then they graduate, and the more resource-intensive treatments like DBT, MBT, and TFP are for people who fail. There still will be lots of patients left, so that there's no absence of patients, but the resources can be used with more discrimination. I think I've said most of this already. There is a theoretical model called interpersonal hypersensitivity that I'll talk about in a moment. This is the handbook which Ivan made reference to, that is not lengthy, but it contains everything that I'll talk about today and more. I picture that at some risk that there might be a conflict of interest. But I'll take my chances. Interpersonal hypersensitivity is a theory about the core problems in borderline personality disorder. You don't really need to have this theory in order to practice good psychiatric management. But in general, it's a good theory which helps learn good psychiatric management. Unlike the theories which were developed for mentalization-based treatment, transference-focused psychotherapy, and dialectical behavioral therapy, this theory developed after the clinical practices developed. It was not a theory which was developed upon which the clinical practices were then followed. And in that sense, it comes because of all the mistakes that I and my colleagues made over the last 40 years, which sort of helped shape a way of understanding borderline patients which help not make those mistakes. So it follows from clinical experience rather than preceded clinical experience. From a conceptual point of view, it's an interesting one because when you put psychopathology into the interpersonal realm, it's something that is inherently context dependent. It's not just in the person, but it is activated and dependent upon being activated by the interpersonal context the person is in. This is hard to come to terms with in the world of psychopathology, where we are always accustomed to thinking about illness residing solely in the person. The clinical and theoretical predecessor for this is Winnicott's concept of transitional relatedness, which exists both within and outside the person. And this is a form of interpersonal relationship, which is secondary to healthy disillusionment. And it is not unhealthy, but it is a state in which the child is both dependent upon and gaining independence from their caretaker. The theory is that this is what constitutes the genetic disposition which the pre-borderline child has, that they are inherently hypersensitive to within their interpersonal relationships, so that from birth they are likely to see mothers frown in more catastrophic terms, to need an unusual amount of caretaking to soothe them, and is consistent with much of the adult clinical literature about borderline patients, that it's the interpersonal features, the intense unstable relationships, abandonment fears, etc., that are the most discriminating parts of the borderline syndrome. It's also consistent with the large and still growing literature which documents how interpersonal events trigger self-injurious behaviors, suicide attempts, dissociation, paranoid ideas, devaluation, and abandonment fears. That is, much of the syndrome that constitutes this disorder is triggered by adverse interpersonal events. And though it's not said here, it's also true that, or maybe it is said here, that remissions are often follow the acquisition of some kind of stable and supportive external supports, interpersonal supports. It's consistent with the childhood literature about childhood disorganized attachments, and the fact that separation problems and hypersensitivity in children predict adult borderline personality disorder. And there's a significant, and I'll return to this I think. Or actually, maybe I'll go to it right now. Neurobiological body of literature which suggests that the neuropeptides are dysregulated in borderline patients and thus provide the neurobiological correlates for much of what is seen in the interpersonal sensitivity of borderline patients. There's a wonderful article by Stanley and Seaver a few years ago which summarizes this, and I expect that I know that there's a growing literature since then that expands on this thesis. There is some hope that in the future, if borderline personality disorder has a medication, it will be one that helps to alter and affect the neuropeptides. Oh, I'm already tiring of my voice. So, any questions or comments? This is still introduction. You better speak up because it's going to be a long day. Oh. All right. Of course I love you. I'm a programmed to love you. I'm a goddamn lovebird. So this is another way of saying that the interpersonal problems that borderline patients have, their preoccupied attachment style, their demand for and need for some kind of exclusive relationship with another person is hardwired into them. It's part of their psychopathology and arguably the core aspect of their psychopathology and should be viewed as such and be a central subtopic, a central focus of treatment. That book that Ivan made reference to in 1984 introduced this slide. When a borderline patient feels held and cared for, what you see is their depressed, waif-like presentation. They're very collaborative. They're very interested in what you have to say. They're very compliant with your suggestions. They're a really great patient. But when it's time for the hour to end, they can transform very quickly into, so you don't really care, or there's something that I really need to tell you, and why aren't you interested? And I will cut my wrists on the doorstep as a sign of how tormented I am by this separation, and perhaps by the hope that you will prolong the hour or see me again. And if the borderline patient has nobody that they are in contact with or feel connected to, attached to, then a third set of phenomena, dissociative experiences, paranoid ideas, desperate, impulsive actions, often under the disinhibiting influence of alcohol or other drugs, takes place. This is a more elegant 2014 version of the same thing, informed a bit by the better knowledge of the attachment literature and by the concepts introduced by Bateman and Fonagy in mentalization-based treatment, so that when the borderline patient feels connected, they're idealized, independent, rejection sensitive, in the face of interpersonal stressors, they become devaluative, self-injurious, angry, anxious, help-seeking. If, when they're in that state, you get more involved, you lean forward, they will calm down and return to that initial state. If, in response to these signals of attachment distress, hyperactivation, I think is the term in the mentalization world, if in response to that you withdraw physically or lean back, then it will activate this further. And the states of aloneness sets in with dissociation and impulsive help rejecting behaviors that accompany it. Here too, going up on the left side, supportive responses return the borderline patient to a state of equilibrium in which they are compliant and grateful and idealizing, and the patient that you hoped you were treating as opposed to the one that you actually are treating. Is that okay? Familiar? Disagreeable, I hope, to somebody. Somebody's got to... I'm going to say some things which are deliberately wrong pretty soon, just to make sure you're listening. So, clinical implications of this are that this sensitivity to whether a patient feels held or not explains the phenomenology. The emotional and behavioral components of the borderline criteria or syndrome are activated in response to shifts in the interpersonal context. It also means for you as clinicians that you can and should become proactive in identifying the interpersonal stressors. It's typical to ask, for instance, when a borderline patient becomes depressed as to what happened or why, and they'll say nothing. And if you're a psychiatrist in the United States, you say, well, then let's add another antidepressant. I'm sure that's not true here in my original home, Norway. But it does happen. In contrast to adding an antidepressant, I would suggest that the newly informed clinician would say, so what happened when your mother visited last weekend? Or I thought that you were having trouble with your girlfriend. And so you become proactive. You don't wait for the borderline patient to volunteer this. You can pretty much presume that if there's a major change in their mood states or their behavior, that it stems from interpersonal triggers. And so you become proactive about it. And that the symptoms, these emotional and behavioral symptoms, are not something you take personally, nor is it personal when you yourself trigger an unexpected emotional or behavioral reaction in the patient. This is the nature of the borderline patient's problems and why they are a patient. 6 overall principles of good psychiatric management. Maybe I slid over that. When the research was done, and I have to say apologetically, there's only been the one trial of general psychiatric management. And so a lot is resting for an empirical base for all that I'm talking about. It rests on this one study, but it also rests on a lot of clinical experience and good sense. And it also rests upon our now knowledge of the natural course of the disorder. But we changed the name when it came time to publishing a book on this the editors said, the publisher says, general psychiatric management sounds awfully bland. Can't you spiff it up? So we changed it to good psychiatric management because we felt now this adjective could be, it was worthy of a more self-endorsement of being a good treatment. But it is, I sometimes regret it because general psychiatric management captures that it is a generalist model. This is not a specialist model, it's a generalist model. 6 principles of good psychiatric management. Be active, not reactive. By active meaning responsive and curious. Patient is sitting there quietly. You don't sit there quietly too. There are patients for whom that's justified, but that's an exception. You challenge them as to why they are being silent and define it as avoidance and challenge their diversions. You are a container by virtue of your sort of responsiveness, but you're holding on to without reacting to the anger and fears and turmoil which you're exposed to. This is a nice video clip if we can get it. Where are you? There's somebody. There you are.
Shooty. Módi. Kecske bombocska. Úgy, szünti. Miért nem lett lelkettél ennyire? Mondja. Jó. Nem tudom meddig tart, de most már biztos vége van mindjárt. Jó.
That's the so-called still face exercise. And it's relevant to this issue with borderline patients is if you aren't responsive, the borderline patient will get very agitated by this. They will experience it as a lack of interest, neglect, or even, as with looking at a neutral face, see hostility in it and get very upset. So it's very important, one of the basic principles with borderline patients, all treatments, you need to be an active, responsive partner. The second basic principle is being supportive. Certainly this was a problem when the treatment of borderline patients was derived from psychoanalysis. The first wave of interest in the early 1970s arose out of Otto Kernberg's ideas about an intensive psychoanalytically based treatment, and a whole generation of us got excited about the potential for treating these patients. The problem was that it eschewed the importance of support. And in the absence of support, it just actually drove patients crazy. And then there's the clinicians like me who thought, well, it must be me. And if I had a better psychoanalysis, maybe my patients would respond better. But it was really inherent in the fact that transference-focused psychotherapy and the way that Kernberg presented it really did not encourage or allow for the fact that these are a group of patients who require a lot of support. Even as recently as 10, 15 years ago in talking with him, I chided him about this, and he said, well, he was afraid that if he talked about the value of support, that clinicians would collapse in terms of their more proactive, change-oriented interventions. They would stop challenging patients or interpreting patients and become just supportive, which I think is an unfortunate one. Transference-focused psychotherapy, as it evolved, included more active integration of supportive techniques over time. And once they started doing that, they learned that you could do the challenging and the interpreting without having patients leave the office. But back then, when it was first starting, it wasn't just me, but most everybody else who was trying to do some version of Kernberg's treatment found that they couldn't keep patients in therapy. So the basic ways to provide support are by active listening, and I mean by that not just that you listen, you actively listen and be responsive. You let the patient know that you're listening. You grunt and you smile and you frown and you're a very present person, and the listening by itself was one of those things that Kernberg always did extremely well. He was very active from the beginning, but he underestimated in his theory the importance of the fact that he was so interactive with his patients. You show interest and you express interest. That's interesting. And be validated. All of the treatments, especially DBT, emphasizes the importance of validation, and it is very important. That doesn't mean that everything the patient says, you say, oh, yes, I understand. One of the more important forms of validation is to say, I don't understand that. That means you're listening, and often enough, if you don't understand something, it isn't very clear in the patient's mind, too. And it's reassuring to them that you want to know and want them to clarify. I refuse to read this. I get mean if you don't. There's that microphone's right over there. Right over there. See that, everybody? Look at that. Look at that. It's standing right there. It's like it's begging for attention. Anybody? You focus on life situations, relationships, and vocation. I had that little thing there, work greater than love. In a case I wrote, I think it was called Ellen, which was published in the American Journal of Psychiatry in 1996, that had Kernberg and Bateman as discussants. I said sort of in a casual way I was telling the patient in this case report that she should get a job as a way of stabilizing her life and taking her mind off of the idea that her future depended upon getting some exclusive partnership with a guy. And neither Bateman nor Kernberg endorsed that idea. That is, Freud said that your life's satisfaction depends upon success in work or love. and I was telling this patient that their life satisfaction depended on first getting success in work, and that their ability to succeed in a world of love is going to depend in large part upon their ability to do that. Neither of them endorsed that. So there I was alone. And I did not have an empirically validated treatment at that time. Aha! Once that study got done up in Canada, I could come back to this message with new enthusiasm. And you'll hear it reiterated during the course of the day. It's important. The relationship is real as well as professional. This is actually easy for most of us. If it's just professional and you hide the fact that you have feelings and that you have a personal life, that's not going to serve your patients well, and it's tough for you to do anyway. And if you are simply there as a friend of your patient who doesn't have a body of knowledge and technical skills and maintains your boundaries, that's certainly not only not going to be good, it's going to be harmful. Change is expected. Come back to this. Another one of those things like work is greater than love, which is sort of one of those axioms which at the end of the day I hope you'll take home with you. Accountability. Expect patients to be active in their treatment. They need to be active. Whether they're going to improve depends upon not what goes on in the office, but depends upon what they do with it between sessions. It's not a treatment that is office-based. It's a treatment in which office is simply a place that stimulates the activities which actually will lead to real change. Okay, this is your big test now.
I had a terrible week.
Sorry to hear it.
Are you now? Well, I'm sorry to inconvenience you.
I'd like to hear more about what's going on.
You'd love to hear more about what's going on?
I would.
Now that's interesting. You are still in training, right? Did your supervisor tell you to say that to me?
You know, Sarah, I really do try and only say things that I mean. In this case, I really do mean, and I'd love to hear more about what's making you angry.
Now that's interesting. You only say things that you mean? You mean everything you say is the truth?
I hope so.
So nothing you ever say is accidental. Everything you say is what you're thinking? I knew it. You know what? If you had to live the way I lived, if you grew up the way I grew up, you wouldn't be so fucking perfect. Look at you with your perfect job, and your perfect office, and your perfect whimsical Monet hanging on the wall. You know what? Maybe you should try to live the way I live for 5 minutes, and we'll see if that plastered little self-satisfied grin's still on your face.
Okay, Sarah, we're gonna have to take a step back here.
You know,
clearly,
Don't take
borderline
this
personality disorder
personally.
is a really, really tricky condition, and I'm not too sure that you're cut out to treat it. You know what? I need a freaking real doctor who knows what the fuck is going on.
Okay, clearly, you're furious at me. And I have to admit that right now I have no idea why. I really care about what's making you this angry, but I can't get anywhere if I'm just fumbling around in the dark.
Guess.
No way, man. There's no way. I've clearly already put my foot in it once this session, and I'm not doing it again
Sense
this
of
time.
humor.
Well, at the end of the last session, you told me that I was going to end up being nothing if I didn't get a job. I already feel like nothing. I already feel like less than nothing, and the one person that's supposed to be supportive of me just tells me that I'm nothing. Do you know how that would feel?
So last week I said that, and this week I said I always mean what I say.
Build a narrative.
I'm really sorry. Clearly I'm not as perfect as you accuse me of being, since I obviously made a royal mess of that one. You know, if I could take it back and do it over again, I certainly wouldn't phrase it that way. It was really clumsy, came across as mean, and it was only half true.
Half true?
Well, yeah, half true. I mean, I do not think you're nothing. I think you're very special. I think you have a lot of strengths. For one thing, you have a great sense of humor. But I really do think it's important for you to get a job.
Here we go again.
I phrased it in a stupid way, but I stand by the fact that I think it will be helpful.
So, responses to that. We're going to take a break in about 10 minutes. And I'm not going to come back. You won't speak to me. Somebody, please. Yes. I'll translate it so you. I'll repeat it.
It's just to calm you down. I don't have a comment to that video, but I noticed that you went very fast over the issue of disclosure in your 6 principles.
The disclosure of the diagnosis, you mean?
No, the
Self-disclosure. Yeah.
And at least here in Norway, they have this discussion. What really is self-disclosure, and how far should you go? Because
Yeah.
your examples here were kind of, yes, I can feel scared or I can understand. But some would go further to self-disclose.
Yes. The comment is that I may have gone quickly by the issue of self-disclosure, suggesting maybe that unconsciously I was uncomfortable with dwelling on that. It is a complicated issue for sure. The background issue is always one is that if you disclose things about yourself, you should always have in mind whether or not this is going to be helpful to the patient. So you don't do it just to vent, though there are times when that's not so bad too. You know, you come into the office after stubbing your toe and you say, God damn it, you know, ouch, you know. That there's nothing wrong with that. There is something wrong with trying to hide the fact that your toe is aching while you're trying to pose as a neutral listener. But the self-disclosures can be quite personal, and including personal vignettes that at one point in my life, I got very frightened about such and such, and I didn't, and you can be specific about it, and it helped me to do such and such. And in that way, using your own experience as a model for one way to approach a problem. Certainly saying, under those circumstances, I know I would feel angry or frightened is another form of self-disclosure, but it's actually modeling and encouraging or giving permission to patients to acknowledge or to examine whether they have those feelings. So there are lots of forms that self-disclosure can take that have very positive impact on letting the patient feel more comfortable with you and that you can understand them. I mean, I think that's one of the most basic ideas behind self-disclosure is to encourage the patient to feel that things that they can't allow into their consciousness or things that they had not thought of are things that are possibilities and things that you would be comfortable with in your own experience. There's much more that could be said about that, but that's, and yes, it does scare me, the subject. Thank you. Thank you very much for that comment. I can continue now. It doesn't take much, you know. All right, so this video, I like this video because it illustrates something that is very important. Borderline patients get very angry, sometimes don't know why, and you respond by remaining curious. You don't withdraw or set limits. Well, she had to set limits. Now, wait a minute. But she did it in the service of saying, what's going on here? And she acknowledged that she made a mistake, but she also didn't fold, so that she said she was sorry, and that's a very important thing in its own right with many borderline patients who never want to do that or feel they shouldn't have to do that. And in that way, a modeling behavior. It also, but she didn't fold and lose the container that she says, but I also still hold to what I said about get a job, so that the containing part of that, her unflinching, taking a stand that she saw as good for the patient despite the anger, is also an extremely important part of maintaining a holding environment for a patient. Okay, I think I've covered that. So, you want patients to be able to make sense of themselves and have some continuity in their understanding of how they got to be the way they are. One of the easiest ways to do this, and that helps build an alliance, I think I'm going to come back to this later in the talk, is to ask them to write an autobiography. Not only is this useful, it's not a particularly useful way to spend time within the office. It's something that most patients can and should do between sessions. And the more work they do between sessions, the better it is. Making connections, as this therapist did, between what happened in this session and what happened in the last session is very good. Looking for patterns and noticing patterns are ways to build a narrative. The GPM approach emphasizes psychoeducation. You don't have to invite or expect your patient to say nod and say, thank you, doctor, I'm so glad you told me that. But it's very important you provide it anyway. They're likely to hear a lot more than they may give you signs of. Non-specific factors are central: reliability, listening. Situational changes can be essential. So don't hesitate if you feel that your borderline patient is in a bad situation to give them the benefit of your advice, even exhortations. If you feel it's something that is important that they change their situations, don't hesitate. Say, look, it is stupid for you to stay in a situation like this. It's only going to be harmful to you. That doesn't mean they'll leave the situation, but they will build eventually a trust in you as somebody who's on their side, because more often than not, borderline patients will continue and persist in situations which they know are bad for them. And doesn't mean you shouldn't explore why they stay in it, but that doesn't mean you back away from taking a stand about what you know is good for them. Every patient's different. Forgo theory if it isn't working. If something is rejected now, don't throw it out. Hold on to it and come back to it when the patient can make better use of it. I don't think there's anything particularly new in this. These are basic principles of good psychotherapy. It's all time up? Oh!
If you could put me on, yeah. I wonder about the bridging of the sessions in individual sessions. Do you think it's important to bridge every session to the last session and to make the coherence more? It's a coherent narrative between the sessions and between what happened in the therapy.
I do.
You do?
I do. It's a good question, and it reminds me of something I sometimes think, but I've never put down in these guidelines. No, I do. I think it's a very good idea to, for instance, I often ask patients, what did they think about the last session? Well, I didn't think about it. And I say, how can that be? That's remarkable. Do you remember what we talked about? Well, actually, no, I don't remember what we talked about. Well, I do. There's something wrong here. There's something wrong if I can remember more about what goes on in your therapy than you do. So that, so you introduce it early and often that this, once again, that whether these sessions are going to be of any use depends upon whether they go away from it and work on the problems, think about it, and not whether you do. They may find it very gratifying, of course they do, knowing that you worry about them, think about them in their absence. But, and so you don't hesitate to let them know about that. That's it's gratifying, but it's also reassuring and conveys something about you being a trustworthy container for their anxieties. But it isn't sufficient. They need to be thinking about and worrying about the problems they've introduced. And what have they done about it? So we agreed last time, this happened to me Tuesday morning, which is like yesterday morning. I had a family session, and they're on the phone, and I'm saying, well, everything is fine. They had a very nice weekend. And I said, well, does that mean, how did it go about not letting Abigail sleep in the house until she's agreed to stop drinking? We had a really good time on Thanksgiving. That's a big holiday in the States. And she had drank a lot and enjoyed herself. And of course, we didn't want her driving afterwards, so she spent the night with us. And I said, well, were you going to say anything about that? I mean, the important thing being in part that there was this breach of a limit that the parents had set, but more importantly, that they weren't going to talk about it. Like, hadn't they thought about what they were doing in relationship to something we've been talking about for the last 6 weeks? They've never set a limit on this daughter of theirs in 25 years. And they finally did it, and she was responding well to it. She comes home, and they dropped the limit, and nobody was going to say a word. I mean, that's not maybe a perfect example, but when patients don't think about something between sessions, that becomes the major topic. This is of no use. It's of no use if you don't keep it in mind. If it's not something you carry with you between sessions, it depends upon being in my presence to think of these things. Yes, it's a very good idea to remind patients of what's happened in the past if they've forgotten. We take what?
Pause. We take
pause.
a break.
One more slide.
Okay.
3 processes of change. You want people to learn to think first before acting. This issue of positive psychology, if you will, that the mission of treatment is not simply the loss of symptoms, but getting a good life and the corrective experiences which occur in the relationship to you and the outside world. With that, we'll take a break. Okay?